We'll start by defining the term mental health and substance use parity. So it's quite a mouthful, but the idea is that health insurance plans must cover mental health and addiction care at the same level as they do other medical conditions. This includes treatment limits such as the number of treatment visits or hospital days, out-of-pocket costs, and the way treatment requests are reviewed, such as prior authorization. The reason that we need to know about mental health parity is that mental health and substance use care has long been shortchanged by the health insurance industry. In the past, if health plans even covered behavioral health care at all, mental health visits were often limited, out-of-pocket costs were higher, care was denied more frequently, and plans were canceled when people used high-cost care such as psychiatric hospital or intensive outpatient treatment. Because of the inequality, federal laws were passed starting in 2008 that require most health plans to cover mental health conditions and addiction the same way that they cover medical conditions. Now, you will find information about this in your toolkit, and again, you could look at that at a later time. So we're going to take a look at the major parity laws that have passed starting with 2008, and you'll see that there are some that were passed on the federal level and here in Tennessee. So we'll start with the Mental Health Parity and Addiction Equity Act of 2008. So this applies to health plans from large employers and Medicaid managed care plans, which makes up most of the Medicaid managed care plans, including here in Tennessee with TennCare. So now this law, this is important, this law does not require health plans to cover mental health or substance use disorder benefits, but if they do, then the treatment limits and the out-of-pocket costs must be at the same level as other types of medical care. So in 2010, the Patient Protection and Affordable Care Act, also called ACA, some people call it Obamacare, it's more commonly known as the ACA. This was designed to reform health insurance. So this law helps people who need mental health or substance abuse care in several ways. First of all, health care plans can no longer turn people down or charge more for having a long-term condition such as mental illness. The law also bars health plans from having a lifetime or annual limit for addiction treatment or mental health care. The ACA is commonly associated with the term Medicaid expansion, and that allows states to enroll anyone in Medicaid whose income is at or below 138% of the federal poverty level, which is about $20,000 or so for one person. But the Medicaid expansion doesn't apply here in Tennessee because our state leaders have decided not to expand Medicaid, which is known here as TennCare. That means as many as 300,000 Tennesseans who fall in this income category cannot qualify for TennCare, and they could be missing out on mental health and substance use treatment. The ACA extends parity requirements to all individual and small group health plans, whether they are sold on the federal government's health insurance exchange or not. It also requires parity in private health plans used in TennCare expansion and children's health insurance plans, or CHIP. So the ACA set up the healthcare marketplace, the healthcare exchange called healthcare.gov, to offer health plans that meet quality standards. So the law made it possible for people to purchase insurance plans online. Again, if you go to the healthcare.gov, And this program offers upfront tax credits to lower the cost of the monthly premiums. And these plans that are sold on the marketplace, according to the Affordable Care Act, these plans must offer 10 essential benefits like inpatient hospital stays, and behavioral health is one of those 10 essential benefits. So in this case, the ACA requires health plans who sell on the marketplace to offer mental health and substance abuse treatment. Finally, the ACA makes it more affordable by setting limits on how much consumers pay out of pocket each year. So 2010, that's a long time ago, and we're still struggling with some parity problems. It took years to get these rules written. Federal and state oversight was really complicated and unclear. Part of the problem was that with the rules that were required for health insurance plans to follow, the rules weren't issued for private plans until 2013 and for Medicaid until 2016. Another problem is that different types of health plans are overseen by different state and federal agencies. So the U.S. Department of Labor does oversight for one set of plans. Health and Human Services does oversight for another set of plans. And for years, it wasn't clear which agencies were charged with enforcing the law. And since the law wasn't being monitored and enforced, insurers at that time didn't have an incentive to comply with the law. Then came along the 21st Century Cures Act of 2016, and that tried to clear up what was required of health insurers and sort out how federal and state government agencies must enforce parity. Now, in this law, it was a very broad law, and parity only makes up a small part of it, but it did strengthen mental health and addiction parity in general. For example, it outlined non-quantitative limits and quantitative limits. And I'll give you a brief explanation on that. Quantitative treatment limitations, or QTLs, they are numerical in nature, such as like the number of treatment days or the number of therapy visits. So it's anything with a number associated with it. And then non-quantitative treatment limits and QTLs, they don't deal with numbers. It's anything that focuses on things like rules, policies, procedures, such as pre-authorization. So the QTLs and the NQTLs are important measurements for whether health plans are complying with federal law and how well they're doing that. Okay. And this particular bill also had a section dealing with eating disorders, which many people don't know the eating disorders are a mental illness. And so the 21st Century Cures Act addressed that as well. So following all the action on the federal level, the state of Tennessee and the advocates here back in 2018 wanted to get Tennessee in alignment with the federal parity laws. And this was a big victory for advocates. It aligned state law with federal law. Specifically, it required the Tennessee Department of Commerce and Insurance to gather information from health plans on how they comply with the federal parity laws. And it also required, for the first time, a report to the legislature in January 2020. Then in 2020, at the federal level, the Consolidation Appropriations Act passed by Congress included a provision that requires insurers and health plans to prove that they comply with the laws and requires them to file annual reports with the appropriate state agency that oversees them. So here, for the first time, we've got like a hammer over them to report, show how they're following the law, how they're evaluating claims, and are they equal to medical and surgical care. And then finally, in 2021, Tennessee lawmakers passed a bill that builds upon that Consolidation Appropriations Act. And now the State Department of Commerce and Insurance is required to get those federal reports and put it in a report and submit that to lawmakers each year. So that is a look at the very extensive history of this very important issue. Now, it's really important for you to know what kind of health plan that you or your patient has. And here's why. Because not every plan has to comply with parity laws. So we'll take a look. Medicare, the federal health program for seniors and people with disabilities, is not under the parity law. And that represents a lot of people. However, there is a bill that's been filed in Congress, actually back in March, that would change that. It's called the Better Mental Health Care Act, Health for Americans Act, and it would require parity for mental health and substance use disorder in Medicare Advantage and Medicare Part D. It would also ensure that Medicare Advantage saving plans maintain accurate and updated provider directories so beneficiaries understand who is in network. Because often what we hear is, and this isn't just with Medicare, this is with many plans, a lot of people don't really know who is in network. They try to make an appointment with a provider. They're not accepting new patients. And so this particular bill would require Medicare to update their provider records. Oh, let me go back a second. State Medicaid fee-for-service programs don't have to comply. This is different than managed care. Managed care does have to comply. So TennCare managed care plans do have to comply with parity. Small state and local governments with 50 or fewer employees don't have to follow parity, but many have chosen to. And health plans for employees of faith organizations, such as churches, synagogues, or mosques, can opt out of parity. Finally, small group and individual plans purchased before 2010, when the Affordable Care Act was passed, they don't have to comply if their plan hasn't changed since the ACA passed. So they've been grandfathered in, but there's very few of them. There are two controversial type of plans that also don't have to follow parity, and this is really important. First, association health plans. They don't have to follow parity laws. They are a type of group medical insurance for people in a specific industry. It allows small businesses to create an association to qualify for savings as if they were a large health plan. So one example is the Tennessee Farm Bureau. They are an association health plan. They're made up of members, and they pull together people, and they can provide medical coverage. Association health plans, however, are not required to offer those 10 essential benefits like on the health insurance marketplace, such as behavioral health. They can actually boost premiums without limit for non-health related factors such as age, where you live, and they can raise rates for women of childbearing age. So people who enroll in these association health plans will find that their insurance won't provide the coverage they need for mental health or substance use care, or maternity care for that matter. So a second controversial plan is short-term limited duration plans. They also do not follow parity, and they have fine print in their contracts that allows them to charge people with mental illness more money. They also do not have to cover pre-existing conditions like mental illness or provide essential health benefits, including mental health and substance use care. So short-term plans were limited to 90 days of coverage and were intended to bridge transitions in health coverage, like a situation with a job change. I, at one time, had a short-term plan when I graduated from college and got off parents' insurance and before my new job insurance would kick in. So I got a short-term policy. And back then, they were only limited for 90 days. Now the plans are allowed to last 12 months and they can be renewed for 36 months. But because of the ability for them to basically discriminate against people for pre-existing conditions, for a whole different factors, they don't have to cover behavioral health care. Some states have actually banned these plans, and others have put 3-month limits on them. So there's a really great research organization called Millman, and a 2020 Millman study showed that approximately 33% of these plans provide coverage for prescription drugs. So think about this, only a third of them cover prescription drugs. Only 42% cover mental health services and treatment. These plans are sometimes referred to as junk plans. And some lawmakers in Congress are pushing to eliminate these, to completely, either to ban them or to make them fall under the parity laws. So this information is also available in the toolkit that accompanies this webinar and is available to you now. So we'll go on to what parity looks like and what must be at the same level. So federal law protects parity in several types of care. So first, inpatient or hospital care must be covered equally in or outside the health plan network. Outpatient care in and out of network, residential treatment, emergency care, and prescription drugs. So they have to be equal, whether it's mental health and substance use care or medical. Parity also applies to cost sharing, such as copays, coinsurance, deductibles, and out-of-pocket cost limits. The goal is that consumers should not have to pay more for mental health or substance use care than for general medical care. And health plans are required to have enough mental health and substance use outpatient providers and mental health hospitals and recovery facilities to serve members close to home. Provider payment rates for mental health must be on the same level as other types of care. You can't pay your medical doctors one rate and your behavioral health doctors a lower rate. And that has happened. And finally, the standards used to approve or deny treatment requests must be no stricter for mental health and addiction care than for medical or surgical care.